And without further ado, Michael Neeki is a person that I've met through this forum and through his growing involvement, as he alluded to earlier, in the ACCP, the American College of Correctional Physicians. He's with the San Bernardino County. He's the Director of Clinical Research and Tactical Medicine at, at the ARMC residency, emergency medicine residency, that is, and he's core faculty in emergency medicine. As you can read on your screen, I'm going to let Michael introduce himself further, and without further ado, I'm going to go to mute, and I wish everybody else would too, please. Thank you.
Thank you again, Dr. Purini. It's really an honor to be here today, and thank you for the opportunity. I have been fortunate to be in the position of Chief Medical Officer for the Department of Probation in San Bernardino County for the past 10 years. But for the past 19 years, now coming 19 years, I've been involved with the adult jail care and prisons while working in a county hospital back there as a faculty. So today I'm going to talk about building and maintaining a community coalition in correctional medicine, which is really dear to me and my team. Many of them are here tonight on this Zoom meeting. Some of the objectives is basically understanding the effective communications and relationship with the medical providers for correctional health, learning about benefits of building of coalition with the specialty and emergency department in the surrounding area, which all of you that have worked many years in this field, there's always an issue with the hospitals when you send your patients, lack of clear communications and so on and so forth. We'll discuss a little bit how forming a public health coalition can positively impact your patients and the community as a result. And then also talk about effective strategies for educating community health providers about the correctional health, using that opportunity that you create. So in general, importance of communication is really crucial to operations in our correctional health. In my opinion, I've seen it for the past few years, and we are improving every day. It seems to me that it ensures continuity of care, timely intervention, especially when you have a comprehensive health management in mind. Reduces recidivism rate through collaboration with mental health. The way that we work is basically it's medical, and many of us that are in the field of medicine, we know that almost 90% of our medical care is the melodrama and hypocrisy and the other things that we have to deal. The 1% that you could diagnose, you diagnose and you could take care of it, but you can't take care of everything else that is not related to you. And that comes with the passion and building relationship. Example of those impact could be access to post-release mental health services, connecting them to the community resources, reducing hospital readmission and infectious disease outbreaks in the community. So it's very important to build that, foster that public safety for incarcerated individual as they come in and go, whether it's a jail or a prison and a juvenile in my case here. So establishing partnership with specialty care and the ED, it's has few steps that you have to take. First of all, identify potential partners. Like if you are in the area where the location is also very important, what is the closest emergency department to you? Will you be able to communicate with those ED providers? Are they willing to collaborate with you? What it takes? We'll go a little bit more in details because I know everybody works in the silo in our operations and in medicine in general. So it's tough to create that initial contact. So initiate contact, reach out to the potential partners, highlight mutual benefits, propose collaboration. Sometimes it would be part of your contract. If you are being hired there, you look for resources and see how can you also value their time by offering some sort of contract, assuring flat rate, whatever it takes to get your patients through that emergency department and get the result done. Establish that agreement ahead of time. So roles, responsibilities. We still have a stigma in our community regarding prisoners and those who are incarcerated patients. As they're coming through, the stigma really blocks a lot of the passionate care that individuals or healthcare providers can provide for those. Um, Implement initiative, collaborate on the joint programs, reevaluate your program once in a while and maintain that.
I did this for him.
Partnership with local hospital is important, especially for your specialty care, reducing costs with the arrangement for the contracts. We do have that, and I'll talk about that a little bit. And then enhancing post-release care, like, where they're going, what's the follow-up, a clear indication of where your patients are going to end up. Emergency department protocols are important too, which, streamlining a transfer process, like can you communicate with the provider directly from the facility as you're sending the patient as an emergent patient to the emergency department, and really verbalize what exactly you're worried about and what you want to be done if it is possible, and then have a communication between the two sides. And how do you integrate the specialty clinic into that? Are they on-site services, or where do you send these individuals that need a specialty care, so you can have that continuity of care and resulting in better disease management? So all of these that I'm talking about are steps that we have really worked on it for the past 10 years here. We're still working on it too, in fact. So benefit of collaboration, enhanced resource sharing, a holistic approach to the patient's care, improve coordinations, strengthening public health and infrastructures. We have clear communication with the public health in the region. And then at the end, you're empowering your patients and advocating directly and indirectly by setting up these resources. Potential outcome, obviously improve health outcome for the patients. Not only that, but also it reduces healthcare disparities. It saves money for the institutions and the community, and increases their efficiency, and really helps the community to come together and increase community resilience. So with that in mind, let's go to a snapshot of what we do in probation department at San Bernardino County. As you know, San Bernardino County is the largest county in the United States by geography. Many part of it, you don't want to be in it. Nothing grows in it. So let me explain about what the main facilities are here. So San Bernardino probation correctional facilities have two facilities. One is in Central Valley Juvenile Detention and Assessment Center, which is in San Bernardino City geographically, and it's operate as a jail, and a high desert RISE program, which is functioning at the prison. I'll go in detail a little bit more. The primary hospital in the county is the county hospital, the Arrowhead Regional Medical Center, which is a level 1 trauma center and regional burn center. That's where I'm associated with. And then our contract hospital is the Loma Linda University Medical Center, which is a wonderful level 1 trauma centers in proximity, and takes care of a lot of our specialty care especially for pediatric population, under 18 pretty much, and some of the subspecialties that we may not have. And I'll go through that too. There are also other local hospitals that we use for super emergency scenarios, a 911 call that needs immediate stabilization prior to transfer. But at the end of the day, we'd like our patients to end up in either of these hospitals based on their need. And then we also have public health clinic that our patients go to. We have contracted dentists, which take care of the dental issues. So is the optometrist. And in addition to that, we also have the county uh, uh, Department of uh, psychiatric, just basically psychiatric help comes from the county Department of Psychiatric Health. This is Arrowhead Regional Medical Center. It's a 456 bed level 1 trauma centers. We see about 100K visit per year. It used to be 128. It used to be probably the second busiest emergency department in the state of California. And it's located by the Highway 10, as you see. And it's owned and operated by the San Bernardino County. It's very rare now to have a county hospital operated by county. In most of the Californias, you don't see that. We do have one. And the Loma Linda University, which you see here, the larger building that you see here, it's just opened up probably about 3 years ago. Very wonderful location and facilities back there. It's huge. It has actually it has 3 different satellite hospitals too, and multiple clinics outside. And it's under contract with us, with the county for all the referral through the county care. So that could be adult or juvenile detention centers. This is our San Bernardino County Probation High Desert Facility, which is close to Barstow, between Barstow and Apple Valley. And it's right now it's called Arise, a restorative integration for successful engagement. What happened is from better part of last year, the Department of Justice in California closed its juvenile system and transferred all the juveniles that were in the juvenile system in adult age, like 18 to 25, and brought them here. And it's really functioning very well for us for the past couple of years. There are like training, there are college courses, high school diplomas, activities, and really so far it's been fantastic, in my opinion. So that's the opportunity for this youth to basically choose a rightful path for their life and come back and integrate into the society. Um, Most of them will stay with us for few years, and then eventually there are placement educational program that will go. The sign that says Las Vegas, so that's LV Las Vegas, and then San Bernardino SB going that direction. This is also our San Bernardino County Central Facilities, which basically operates as a juvenile jail to age 12 to 18. We may have 19 too, but they stay there for a little bit, and then they either integrate into our Arise system, or they may go back to court to determine where they have to. This is basically a revolving door location for us. We basically have maybe 100 to 130 that come through on a daily basis, and they go through, and all of them. So the difference between the cares in our Arise program, we have more chronic care issues that we have to organize, and then here is more like emergent and issues related to coming in with unknown entity till we figure out where we're going with it. A little bit about the fact about San Bernardino by itself. Designated as a county in 1853. As I said, is the largest county in the contiguous United States. And the population is about 2.2 million. And most of it is just located right here at the Highway 10, as you see. And OC, Orange County, that direction with the Riverside also there is about 20 miles to Riverside, and then about 50 miles to OC line. And then LA County will be about 40 miles to west, and going Las Vegas. So the 2 circles are the location of 2 hospitals. So they are located right on the corridor of 10, which is majority of our population. Majority of our population also has Hispanic, Latino, and then the percentage of white and African American and Asians are also noted there. The distance, the traffic, if the traffic is okay, it will take us about hour 20 minutes of transfer from high desert to pretty much to the ARMC for our clinic time. But if an accident or something happened, it could be hours. So we have actually contingency planning. Something else also we have implemented about 10 years ago was that you do not need to have a medical clearance by hospital if your vitals look okay and you GCS 15. You can go to our facilities and the nurses will call me 24/7 to get a clearance to bring in. So that really decreased the number of ER visit by, I would say, 99.9%. So partnership with probation and ARMC, how it works. Um, County departments work together as a contractual agreement. So probation department has a contract with ARMC. I am personally, I'm part of a group called Y2D, which are ER physicians, psych services, orthopedics, anesthesia, internal medicine, hospitalists. And we basically ventured out by invitation. How I started was basically 10 years ago, a little bit more than 10 years ago, I was invited by a fantastic, rest in peace, nurse manager, Sharon Jacks, who wanted a better care. And doubtfully, I basically got my toe wet and looked around and I saw, gee, really, I could do better. And I didn't know anything about this standard. I basically set the standard at highest possible. And that's how we started the cooperation between ARMC and the probation department and the jail too. So this is how we integrate. Basically, we have continuity of care because CMO and probation and ARMC are basically integrated together as one. It's a hospital-based operation. And only for emergency cares, we use other emergency department, or specialty care, we use Loma Linda based on our contract or other services whatsoever for the benefit of our patients. In general, we really don't have a waiting time. Like when I remember when I started here, we may have had like 3 months to 6 months to see a cardiologist or get an echocardiogram. We cleared that within 2 weeks by bringing all of those guys into county hospital as emergency and get them up into the cardiology clinic to get all the echoes and clearance. So our biggest probably referral is orthopedic and self-injury. So it's all bone and punched here, punched the other, or lacerations, things like that. Otherwise, it's really a mini adult with known problems that everybody knows about. So we basically have patient access to patients' medical history. The two systems that we use, Epic and the Tech Care, are not compatible, but we use both. We have access to both of them to look at the patient's history and what they have done in the emergency department or the floor. Our providers also, since it's from same group, they will call each other before the patient goes and they can communicate with me pretty much to have access to everything that patient would need. Again, communication is on-site and off-site. Medical providers are direct. We basically ensure that patient gets the care that needs. Like last week, I had a youth that went down there and the patient's exam showed that he had possible ACL laceration and a rupture. As he was in the emergency department, I talked to radiologist and he said, yeah, I could do MRI right now. So we got him through MRI and he had a diagnosis and we set him up with the ortho within a week. So that's how it goes. Like, it's really one thing that every one of us believe, and that really the medical care is a basic right for these individuals. So we should really expedite their care as good as we can. The way that we work, the electronic medical record, as I was talking about, it's Epic in Loma Linda and ARMC. So we have access to chart reviews and everything, and then a Tech Care in our facility. So probation health department cannot directly integrate, but we can transfer the data between the two systems. We also have a wonderful system placed for what we need to do with the help of our case manager. So what we do is basically our hospital, primary hospital, the county hospital serves as about 90% of our care, which covers all the orthopedics, all the general surgery, all the issues related to ER, um, depending on the age, neurosurgery or oncology. If not, then we transfer them to Loma Linda uh, for hematology, oncology, derm. Derm is a big thing that we send down there. Pediatric cardiology, we get there if there's severe DKG or any congenital issues. I've had quite a few over the year. We also implemented from 10 years ago a blood STD panel, which is HIV, hepatitis C, and syphilis, in addition to urine, gonorrhea, and GC. And within that period of time, every year we pick up 2 or 3 Hep C or HIV in like 14 or 16-year-olds. And as a result, we refer them to the infectious disease at the Loma Linda, in addition to public health, um, after our own education and the start of medications. Public health is also very directly involved with us. A good thing was that the current director in the past few years was my regional director for Vituity. After his retirement from that, he picked up and he's very passionate about improving all the care, including MAT programs. So how do we do release and aftercare? We basically have a case managers that sets up their appointment, follows up with the parents, guardian, or probation officer, and make sure that meet. We can't do 100% obviously, but we make sure that they know of how important it is to follow up. And if they can't get a hold, they can just come through the ER and ask for me and go through it. That's the contract that we have. We also use the pharmacy system at the county hospital for majority of our work. For the psych and 30-day supply up and release, we use any pharmacy that is acceptable to the patients and close to patient. So in general, the structure that we work is medical providers provide on-site medical service in correctional facilities and at the RMC. So both of them, they are familiar with both facilities. We use other localities if when the transport to the county hospital would be detrimental to the health of the patients. So, road emergencies or issues related. We had cases that looked like a stroke, so we went to closest. We have on-site case manager, as I spoke about it. It's been a tremendous advantage to our patients and ourselves for easing our, continuation of care and transfer of the patient's care to the community. And then a county hospital is a primary hospital for emergency department and specialty care. But now we have also, as of May, have access to their family practice clinic and their addiction care clinic. So in summary, we basically have a specialized care, continuity of care, timely access to the service. We address the legal and ethical compliance. We really don't have an issue with that because everybody is getting better care than my kids. That's what it's on the table. Everybody believes in it. Community integration and support is tremendous for us. We have communication with all the hospitals and try to really be resourceful and resolve any issues that may come up. Our managers, health directive managers are wonderful and proactive in communicating with other departments. And we really optimize our resource by communicating with each other. That's the summary of my presentation. I know I went kind of fast, but I wanted to give a little bit of time to everybody to talk about their system if they wanted to compare it and give me a little bit of a feedback on.
I have a question.
Sure.
How successful have you been at getting like EMR access? I know you mentioned that like they weren't compatible, but when you've reached out to different hospital systems, have they been willing to give you like read-only access or how do you access those records for?
So with the hospitals that we directly contract, we have a providers have a all access. So we basically can download their current diagnosis, all the workup, all the notes. However, our nurses have just read access to those.
Mike, was that difficult to get? I mean, there are some places that really struggle with that, where the hospital doesn't want to release it, HIPAA
So,
regulations, et cetera. How did you dig through some of that bureaucratic red tape? I think
so
that's the secondary question.
yeah, so we still have some issues with some of the small ERs on the hospitals. We don't have a 100% access, but that's only less than 1% of our patient that goes in emergency scenarios to closest ER. And with that, we get paper discharge. Some of these guys actually work with my group, so I still can call them if I have a particular questions. With the big agencies, that's basically a provider access. The reason is because I work in a hospital, I have an Epic access. Therefore, Epic has a contract with Riverside County, Loma Linda, major big hospitals around here. You can have access to any of those data as long as they are your patients. You basically click on it and look at what they have done for the patients, and then communicate with the providers if you want to.
Wow, I think it looks like great job, Michael. I think it seems like you guys have such a great camaraderie and relationship. Maybe it's because it's a sort of restricted area, but that you're able to just pick up the phone and talk to someone, and the communication seems to flow so well. Is that just a result of you being on staff at multiple hospitals, or how many physicians are in this group? You mentioned
So
that you were within a
my
practice group.
personal that's a great question actually. So Y2D also has the contract for the adult jail, which is an additional 4 institutions throughout the county, and they are also busy. They see about 8,700 patients per month. So it's a busy operation for them too. But we do the same thing. So I basically coordinate with them. I consult them on their own operations. They're actually right now trying to get out of the court monitoring and come into NCCHC scores. But in reality, my operation is small because I don't have that many patients. I have I used to have uh, uh, so I have a PA and an MP and a couple of residents that used to do moonlighting with me in the operations. Then we have a separate psychiatric services, which has 2 psychiatrists and then chief psychiatry officer and a fellow that comes in and takes care of the psychiatric issues. We also have 1 dentist and 1 optometrist that serve the medical and integrated health. In reality, a lot of my work is done really with the team members, our nurses that are assigned to being a case manager, to follow up, make sure everybody is okay, and then they will let me know where do they need help, and then we see how we can knock on the door and ask for help. It took a little time to set it up, but it definitely helped for us to be part of the county. We are integrated in the county operations, hospital operations, the C-suite, the downtown supervisors. So that way, if we have any issues, everybody will access us, talks to us, and this is really a good way of setting up a smaller program, but then expand on it. In my opinion, it might be difficult, but I know that some folks have like contract with like directly with the sheriff department or with the jail. Well, I think part of that contract should be you should really look at where your patients are going to go, which is the main hospital that they're going to go. Can I communicate with them, add some benefit to that hospital? Let's say, okay, I guarantee that you get a flat rate, for the patients, but I need to have your medical director have a direct communication with me to make sure my patients are taken care of. these relationships are very important. You have to play the politics in the region. Otherwise, the silo operations that we had in incarceration incarceration medicine needs to change, in my opinion.
So, Michael, you mentioned a little bit about the flat fee. So, my question to you is because you're part of the county, and
Yeah.
these are county hospital, which is a great thing.
Right.
Is there any other like supplemental like billing that goes on?
Yeah. So the patients that are going from any jail, county jails, county facilities to the county hospital, we have a flat fee charging $60. It doesn't matter what you see. Critical care, non-critical care, procedures, no matter what. The numbers are $60 a piece. And we can negotiate that. We were just talking about that to increase it at least to the Medi-Cal range and stuff. But that's what we contracted a long time ago. So that helps to see, okay, you guys are getting the money. I need a service. I need to go down there. But on the other hand, Johnny, it was a very good question. In my opinion, you could basically go to that closest ER to you that all of your patients are going to go and say, okay, medical director, what do you need for me to be in contact with you and have a good relationship? Is it a contract-based stipend, whatever it takes? Because I know they are busy too. They don't, medicine, obviously, the bottom line, they have to answer to their own partnerships or whatever operation they have. But for us, it never been about the money. It's once we put our foot into this, I personally, it opens up my eye to a different part of humanity in my opinion. You realize how much people are in need and worried, and you could say, okay, this part of your life is taken care of. Now, focus on the other side.
Michael, I think it's really timely and interesting, the talk, because I spent the day today actually working on, and I'm on the county side, right? Like I work for the sheriff's office, and I think this is because you're in California, there's so much, this is so important because of Cal-AIM coming along.
Right.
And then for other states that may be on the call, the other 1115 waivers that are happening around the country and are going to continue to happen. I spent the whole day today talking about health information exchange and community information exchange with our Medi-Cal, MCP, our managed care organization, and with all of our different county organizations, including some community-based organizations. And I really don't think that without having the kind of communication you're talking about across all of these agencies in a protected manner, will we be able to really fulfill the patient-centered care that's really required of Cal-AIM and the 1115 waivers. And so you've sort of started on like you called it, a smaller scale or smaller hospital, but we're really going to need countywide. The county is actually going to have, for us, the county administrative office is actually going to have to push this, that electronic ability to communicate with each other.
So that's a very good point that you brought. In fact, we have started that negotiation backdoors. Now we have a group that we're talking to our largest managed care providers, the IEHP, Inland Empire Health Plan, which is like a couple of $1 billion contract that they have with the state. So these guys are, 1,000-pound gorilla around here and are willing to do that with us. They are willing to actually work with us on that, because the bottom line is that Cal-AIM, if it really realizes, they know that there's a potential for not only benefit for the patients, but also financial reward for all the providers.
Can you just briefly tell us what Cal-AIM means?
Yeah.
I don't, and many in the room don't.
Well, yeah. So California is starting a program, and I wish I knew all the details. Even the guys who are implementing are not sure, but the target is somewhere around September, October of this year. Any individual that stays 90 days into your system can actually qualifies for Medi-Cal level billing by the by the authorities or medical care at the prison and the jail. So that means we can start actually billing for our care and also have that continuity of care continues to the managed medical and the community through that process. It's a really unknown process right now, Mike. If I wanted to describe it, it could be really rewarding for the county's operations and the jails, but we're not sure if the county can really, if the state can actually afford that at this point because of the
Understood.
budget cuts and the stuff. So uh, practically, they're saying that you can bill like a clinic if you're seeing the patient in a screening area and all the care that you provide throughout their stay, like code, like ICD-10 code into the medical, which I doubt it is going to be practical with the amount of budget cut that they're going through right now. So we'll see. But if it happens, it will be a first probably in our region, at least west. I don't know if there is any east that exists, but I know that New Hampshire is always ahead of, that area. Sometimes they are ahead of
The
curve.
Northeast.
Yeah.
I have a question for you. I work with a system where there's months of delay in getting people into the to specialty care. And of course, it varies according to specialties. Neurology is particularly difficult, etc. And I guess I wonder, how do you get started on something like this? I think that's really the fundamental thing. They've actually finally gotten EHR access, which is better apparently than St. Luke's and Boise. Kate Wilkes is telling us that there's no way that they will be allowed by their primary hospital to look at their records, which I think is ridiculous. But anyway,
Yeah. So
something. Where do they start? I mean, where does the medical director or the regional business person, where do they start?
I'm not sure if this is how you need to replicate, but this is how it works for me. I'm a chief medical officer for this department. I have another chief medical officer for the adult jail, but we have a regional director is also our medical director of the whole ER operation in the region, Rod Borger. And what it takes is basically we sit together and we talk, and then we'll talk to everybody else that we need, the director of the cardiology, the director of neurology, neurosurgery. So I have a direct access to these guys because we really sit around the table, we operate together, we practice together in a hospital. We use that backdoor channel to basically open that opportunity for our patients. So if I need a cardiology, the cardiology, as I remember when I took over, there were probably about 12 or 15 echo that was sitting down there for 6 months. We were able to clear that within a week. We brought him into ER, like 3, 4 at the time, sent him up into the cardiac suite, and the cardiac manager back there, she was a good friend. She took care of all those. I'll do it for Dr. Neeki. So we went through it. So that's how we do it. We basically use the backdoor channels, whatever is possible, to get these patients the care.
So
Yeah,
so let me be clear. You've been in that community for 20 years. People know and trust you.
yeah,
And that's part of how to get your foot in the
exactly.
door is
Yeah.
through establishing a relationship with
Yeah.
people, through people
We
who
don't
are
operate in
trusted.
silo. I don't operate in silo. I'm involved with fire department, police department, galas, donations, volunteer work. And through that, you meet different physicians, different managers, different individuals that really are at your level and care. My partner is here right now, Troy Pennington. He's director of county fire, but he works with me also. And we've worked on this for past 20 years together to just make sure that everybody it's working with us on the same page, but we are also available for them if they need us.
I think Mike Greeny, I also think that it's going to be it's going to be for every individual location is going to have their own recipe. Mike found a really good one that works really well, and part of that's because he's got a county hospital and he's got the connections. And once you're in the same, once it's the same sort of network, it makes it easier. It would definitely be harder. And you were talking about Idaho, or it's definitely harder if it's a private hospital that you're having to work with, that sort of thing, because they may not necessarily want the patients or the Medi-Cal reimbursement, and they lose money on every patient. And so we've got, in our county, we've got 4 hospitals, 2 different companies, 2 different big giant hospital companies that are not part of the county. We don't have a county hospital, so our relationship with them will be very different, and with the other agencies will be very different than maybe Mike's is.
Yeah, but Seth, you can set up your own operation with that CEO of that hospital. That, hey, if my patient comes there, can I give you a medical rate, twice a medical rate, whatever it is, so we can set up some relationship. They would love that rather than giving a care for free to someone.
Right, and I think that's one other little piece of ours is that we've got a private company delivering the healthcare and the health, medical, and dental in our jail, and so we've got that company's going to have to be involved in all this as well. And so if you're paying a flat fee to a company, that's again another scenario where there needs to be that sort of negotiation and that relationship.
I totally agree with you, because one of the issues is that right now you come in and underbid another company and take the medical services, right? So you basically working in silo, only serving that population in that institution and have nothing to do with outside. Whereas if I was a smart company and caring company, I would also consider to communicate with my closest hospital and say, okay, I'm putting for this contract, I'm going to add another, a segment of relationship and maybe a stipend for you guys to work with me to have a successful operation. Most of these silo operations are pathetic, and that's how we get into trouble for patient care, because all they focus is their medical aspect of it, and they don't care if you get an appointment or not. Well, I referred you, you have to wait for 6 months. But am I trying to do anything to cut down that 6 months to 3 months or 1 month? Probably not,
Michael, I'm going to jump in again and just say that there's a lot of chatter in the chat box, and I'm monitoring that for you, so you don't have to bother with it, about access to hospital records again. And apparently there are lots of systems out there that we can't get a hold of the medical records on our own patients. It seems like access is the easiest way, because otherwise you have to have a secretary faxing over records or
right.
something old school like that. That's very, very time intensive for staff.
Yeah.
And I guess I wonder, do you know of maybe this is a talk for future meeting, but do you know of any barriers what are the barriers for getting a hold of medical records on your own patients through the EHR?
So first of all, they have to have same EHR system as yours, probably, like being compatible, or you having access to that EHR. For us, for example, Epic is it's a new, system in a block for the past couple of years. For most of the hospital in the region, they're moving into Epic. It used to be Meditech, and Meditech was basically a silo operation. We couldn't have a communication with anything. Epic right now has over 183 like large system that you can hit in and get any of those medical records.
I'll let it be, but I'm gonna still just, the same thing you're doing.
Yeah, wonderful.
So with Epic, there's an outpatient providers portal to be able to transfer and review charts. So that I think California and Washington states are 2 that have access to a very cheap version, like a what we call Epic Lite.
Okay.
for their county jails. But the rest of the country, we don't have access to the opportunities like that to participate in Epic Light.
So Johnny, we don't have an Epic in the jail system, but we have actually negotiated with them to have a read-only access for our nurse. And then for our providers, since I work in a hospital, I have a full access under my staff privileges.
One of
think
the
that's
things,
what-
sorry.
Go ahead, Seth.
One of the solutions, I don't know if it's going to be, I think one of the solutions is going to be something that these larger electronic health records already do, like Johnny just talked about, sort of Epic Light. Cerner's got something called Community View, similar kind of a thing where community providers can go and look in and see certain information. But they're basically all health information exchanges, and there's several companies, some of them large, doing that kind of work now, where it's like a middle place where data can be stored and nobody can mess up the data in it from either end or from multiple different ends, but the hospital their data can flow in there, and you can get that from and the jail can send data and receive data from this more sort of safer portal. I think it works with HL7, but basically you've got that, and then even beneath that, the way, again, this CalAIM thing that is going to probably spread around the country over the next several years. One of the requirements for this whole thing is for there to be much more expansion of services offered under Medi-Cal in the community. So you're talking about housing and food and job searching and all kinds of extra services. And so those are going to largely be these community-based organizations who don't even have an electric record. They might not electronic health record. They're keeping track of things in paper, or they're using something that might be a homeless information management system or things like that. And all of these are going to need to communicate through a bigger system, whether it's Epic Light or a different HIE, who are going to need to communicate, I believe, over time. And those are available, and and if expensive, are going to probably need to be government's probably need to get involved. Hospitals are going to need to get involved to make sure that it's that these smaller agencies, and even down to the county, that they can afford to get access to be able to communicate with each other.
So from what I'm
Understood.
getting, the low hanging fruit would be for the medical directors and providers to basically communicate with their main hospital, maybe have privileges there and have access to that. So that could set up and resolve 90% of your issues. The other 10% for other institutions or emergency cares are usually not that drastic. You could probably get that paperwork and read it, but that's how we did it. We pretty much have privileges in our main hospital. From there, we have access to Epic that allows us to hit every hospital that have that system in our region, and it's working well for us. Frankly, we use every little thing that we could get. Our case manager, for example, his wife works in a hospital, in a GI clinic, and he was able to call his wife and get an appointment for one of the patients to get a colonoscopy faster. So we do whatever we can. I mean, it's a backdoor channels, whatever we can pull off to make sure they are okay. I mean, there are patients that come to me from DJJ with a complaint, with a lawsuit. And as soon as they get to me, we'll sit together in a room, we'll talk about the care. And after that, everything, it's fine. We'll set it up. I need an infusion. We couldn't get a specialty clinic to infuse for him because it was off the track and insurance issues. I set it up in ER for him to do it. So it's just whatever it takes to serve your patients the best way you could.
Yeah, so and I think I heard you say that a lot of times it starts in the emergency room, but then you can involve the other specialties in the
Absolutely.
process. But that for you, especially as an emergency room physician, you were able to start it through the emergency department.
Yes.
Was I hearing
Yes,
that
yes.
right?
Yeah. And also My providers right now, they all have extensive experience in the emergency department. So we do many procedures right there in our facilities. You know, orthopedics and splinting and reductions, INDs and packing, anything that would need to be there because they have done it before. So we don't need to send them to a hospital. And then on the top of it, I've been 24/7 on call for the past 10 years. So
Well, that's not okay, but
well, it's if you set policies and procedures and educate your team, uh, you don't get that many calls, you know. So we do annual nursing education and case-based now. It moved on, so it showed a lot of progress into that. It I really every time that I talk about it, I say I'll challenge anybody because I didn't look at NCCHC or such institutions to set my standard. We just set the standard the best we could, and when we looked at it, we surpassed all the requirements, basic requirement that was there. So
anybody else?
I think it's a wonderful system, and I think Michael, you're the key part of bringing it all together. So, kudos to you for doing that. I think it's getting to know, like you said, the ER and getting involved in your community. I think, sometimes for us, our providers, are very focused on just doing whatever it is that their company or their county jail wants them to do, and nothing more. So, but you're right. I think people need to look further out. I mean, I to me, your wonderful model, it's very similar to what I've experienced in seeing, Cermak, Cook County Jail, same thing with Harris County, Dallas County, where they have, the county hospital and county health department working together. And so it all works out. Unfortunately, there are a lot of county jails and a lot of prison systems where we don't have those connections. And sometimes it's just very adversarial to even begin with. I know I had a challenge when I had to deal with the Department of Corrections in Guam, and it took the lieutenant governor to tell all the agencies to work with me to bring it all together. So I had the fire department train the corrections officers CPR. I got the local hospital to provide the medical staff and the nurses, and then I actually got the naval base to actually deal with our trauma, and so many other agencies. I mean, I can go on and on and on, but it takes time and to build those relationships, but they're worthwhile when that does happen.
thank you, Jenny. I agree. I think at least the leaders should expand their horizon and look for more solutions than their own operators, because I understand operators are there for 9 to 4 or whatever.
Well, Michael, I really appreciate it on behalf of the ACCP, on behalf of the participants in the room, and I think this was really, really informative to those of us who needed this kind of information. Really appreciate you taking the time. And unless there's something else, we're 4 minutes early, which is kind of an oddity for us, but I don't see any reason to prolong it. So everybody have a good evening.
Thank you
Unless
so
there's
much.
something else that there was a comment in the chat about getting the charge nurse in the ER to help with scheduling outside visits, and I think that's just another example of
If it works for
doing
you,
whatever
great.
you need
Yeah,
to do
yeah,
to get it to
yeah.
make it happen.
I know
And
it won't work for us, but if it works for you, that's great.
all right, well, take care, everybody. Thank you very much, and see you next
Wonderful.
month. And
Bye.
everybody, remember our national conference is in Salt Lake. It's a great city, and we're going to be having our conference of September 7th and 8th this year. And registration and hotel registration is now open. Thank you.